So good evening, ladies and gentlemen. Thanks for joining us on this first of the four series um, webinars, or I would say this is more of a town hall type of a meeting where we have experts from the Midwest Heart and Vascular, as well as the Kansas City Heart Rhythm Institute to really talk about cardiovascular diseases. February, as you know, is the heart month, and there is an increased awareness and desire to learn more about heart diseases. And so we got world-class experts today with us. My name is DJ Reddy. I am a cardiac electrophysiologist, and I'll be moderating this evening. And I would like for our other speakers to introduce themselves.
Rachel Sosland, cardiologist with Midwest Heart and Vascular Specialist.
I am Karthik Mani. I'm a cardiologist at Midwest Heart and Vascular.
Hi, everybody. I'm Vasvi Singh. I'm an imaging cardiologist with Midwest Heart and Vascular.
Hello, everyone. I'm Rajesh Kabra. I'm a cardiac electrophysiologist with KCHRI.
Excellent. So we got a whole range of specialties represented here today. So, Dr. Mani, what is this cardiovascular disease?
It involves a wide spectrum of diseases that affect the heart and blood vessels. And, it starts with things as like, which we commonly hear about, which is blockages in the arteries causing heart disease or heart attacks. And then you can have issues with arrhythmias where irregular heartbeats can cause problems. And then, you can have problems with heart valve disease. Ultimately, all of these diseases come together and will cause changes in the functioning of the heart, which can sometimes give rise to what's called heart failure. I guess this overall group of diseases would come in as what we call cardiovascular disease.
So, Dr. Sosland, can you talk to us a little more about various categories of heart disease? Like, what are some of the most common cardiovascular diseases that we should be aware of? How are they different from each other?
Sure. Thanks for asking me to be a part of this great talk tonight. And I'm going to kind of explain these generally because you could honestly spend hours and days and whole classes learning about each of these individual topics. But coronary artery disease in itself is when the blood vessels that supply the heart start becoming narrowed. And that can be from blockages, from cholesterol plaque building up, or from clots forming in the heart for various reasons, but the blood flow is not getting to the heart. And we consider that coronary artery disease. Another term on this list is atrial fibrillation, which we're going to, I think, talk about a little bit more later. But what happens is when the rhythm is out of sync and the top chambers of the heart are not working in sync with the bottom chambers of our heart. And so blood can start to pool and we can get clots, and those clots can then go to the brain and cause strokes, and that is why it's so significant. Another term that everybody's heard of is congestive heart failure. There's lots of different types of congestive heart failure, but the main reason it's called that is because the heart is not strong enough to pump enough to meet the body's needs, get enough oxygen to the body. And so what happens is fluid starts building up in the lungs and the tissues and the other organs. And so you can get various symptoms related to congestive heart failure, like shortness of breath or swelling or unable to lay flat at night because you're possibly have extra fluid. And then another category is valvular heart disease. And so this is when the valves in our heart are not working well, either because they are narrowed or they're leaky for various reasons. And so this prevents typical normal blood flow from getting through our heart, and then can lead to other conditions and other symptoms.
So it looks like these are some of the broader categories of how cardiac conditions are sort of divided up. So, Dr. Mani, when you look at these different categories of heart disease, what are some of the most common and important risk factors that contribute to these conditions?
I think the biggest risk factor that we deal with is aging. As people get older, the prevalence of heart disease goes up with age. Secondly, I think, we have to consider high blood pressure or hypertension as the second biggest factor, and this is often associated with aging itself. One of the factors that we can't change at all is going to be our genetics or our family histories. An important risk factor for developing these blockages is abnormalities in our ability to handle cholesterol. Not just high or low cholesterol, but actually abnormal cholesterol patterns that cause blockages to occur in the arteries because of disorders in the way the blood vessels handle the cholesterol. A lot of this can be from physical inactivity, especially in people where we're dealing with obesity. One of the good ways to injure these blood vessels is to smoke, and the results of tobacco entering the bloodstream very often causes injury to the blood vessels that makes them more predisposed to developing heart disease. And a particular problem that's usually a sum total of all of these is developing diabetes, either type 1, which is congenital early onset diabetes, or type 2, which is more from insulin resistance.
So, I mean, obviously, you can change who your parents are, and so I definitely see that there are some of these risk factors that are modifiable and some are non-modifiable. So, which one of these risk factors that you alluded to are modifiable risk factors as against non-modifiable?
You know, as you correctly pointed out, family history is hard to modify, but almost everything else which comes to heart disease is something that can be at least addressed or remitted. So, people can work towards decreasing tobacco consumption. Physical activity is an important way to decrease the impact of obesity. Being one of the biggest things with hypertension is under recognition. Most people with high blood pressure very often will not be recognized for decades, meaning that they have decades and decades of injury that's taking place to their body in a completely silent manner where they are completely asymptomatic. Similarly, most people with high cholesterol aren't screened at appropriate times. So, very often, screening for high cholesterol starts at age 25. You do the first blood draw at that age to make sure that you identify people who have a propensity to high cholesterol, particularly when they're associated with a family history. And the same thing is true for diabetes as well, where identifying it early means that you can institute clinical measures that will decrease the impact of the diabetes in terms of developing heart disease.
Thank you, Karthik. This question is for Dr. Singh. So, as a lot of times people talk about premature coronary artery disease and significant family history of coronary artery disease. When should somebody be concerned about this history of coronary artery disease? At what age, at what point in somebody's life should look at this and go, okay, I need to go see a cardiologist to get this sorted out?
Yeah, thank you for the question, Dr. Lucky Reddy. So, having a family history of coronary artery disease or CAD, specifically if a male relative was diagnosed before the age of 55, or if a female relative was diagnosed before the age of 65, doubles your risk of heart disease. So, important things to understand for a particular patient is that they may need to start screening for numbers such as blood pressure, cholesterol, blood glucose much earlier in life. They may need to see their primary care doctor or, if needed, a cardiologist to better understand symptoms such as chest pain, shortness of breath, or unusual fatigue that may actually represent heart disease. They need to adopt protective lifestyle habits such as a Mediterranean diet, a DASH diet, along with regular exercise. Avoid smoking, and then discuss advanced testing with their doctor, such as a coronary artery calcium score, especially if they have a family history of heart disease, so they may understand if the disease process has already started in their heart arteries.
Looking at one reversible risk factor, as Dr. Mani pointed out, hypercholesterolemia is a big one. Do you think everybody above the age of 50 or 55 should be on a statin?
Yeah, I think, the answer for that question is a lot of us may benefit. There are certain risk calculators that your doctors can do to classify individual risk for each patient, depending on if they have pre-existing high cholesterol levels, blood pressure on medications for them, or for example, if they have diabetes mellitus. If the risk number of the incidence of having heart disease is high enough in the next 10 years, then yes, the patients may benefit from lipid therapy such as statin. The other thing is, the coronary artery calcium score, in addition to blood pressure numbers and cholesterol by itself, provides a much higher stratification for risk score. So coronary artery calcium score can also be used to identify if a particular patient population will benefit from a statin or would be okay in withholding statin at this time, depending on individual risk.
So, is there evidence that taking a statin could actually reverse this plaque buildup that we talk about over a period of time?
Yeah, that's a great question. So, there are two kinds of plaque buildup that happen because of the hardening or aging of the arteries through a process called atherosclerosis. So, usually the old plaque is the calcified plaque that we see in coronary artery calcium score. The statins, they actually change the lipid-rich plaque, or what is called the soft plaque, which is the more dangerous plaque that causes events such as stroke and heart attack. The statins change this high-risk, soft lipid-rich plaque into a more chronic, stable, hardened plaque. So overall, though the plaque burden may remain the same, the quality of the plaque changes from a more aggressive form of plaque that may cause heart attack in the near future to something more stable that can be managed with medications. So overall, if one may follow coronary artery calcium score on patients that are on statin therapy, the coronary artery calcium score by itself may increase. But if you do a coronary CTA, which is a more specialized test that requires iodinated contrast, or what we call dye in simple terms, to look at the complete lumen of the heart artery, the plaque will actually get better because the quality of plaque went from becoming more unstable to stable plaque. So the statins contribute to improving the quality of the plaque and therefore reduce the chances of having a heart attack or a stroke in patient populations.
It makes a lot of sense. So basically, taking some of these cholesterol-lowering medications really changes the risk profile, both not only in terms of the numbers of cholesterol levels, but also more of at a vascular level where you are really stabilizing a lot of things. Thank you. It was a good explanation for our audience there. This question is for Dr. Cabra. So, Dr. Cabra, atrial fibrillation now seems to be in the air. It's everywhere. It's on TV. It's on newspapers. Everybody talks about AFib. Why is this atrial fibrillation such a big topic nowadays that it didn't used to be that way a few decades ago?
I'm just going to build up on what Dr. Sosland mentioned for the audience who have just joined us. Atrial fibrillation is an irregular rhythm where the upper chambers of the heart, they are beating asynchronously, and that causes a disorganized rhythm. And the importance of atrial fibrillation lies in the fact that it increases the risk of having stroke. So to Dr. Lucky Reddy's point, there has been a lot of buzz about atrial fibrillation recently, and I think many factors are contributing to it. Number one is as our population is aging, we are seeing more atrial fibrillation. I think there are some estimates that about 6 to 10 million Americans have atrial fibrillation, and this number is going to double in the next few years. So I think with our aging population, we are diagnosing atrial fibrillation more and more. More importantly, with the current gadgets that we have in terms of smartwatches, in terms of the fancy rings, or which check the heart rhythm of patients, or blood pressure monitors which alert to any irregular rhythm, or there are a lot of advertisements on the television where you can take a small patch, put your finger, and which will generate an EKG on your phone. So I think with all these devices which have really made arrhythmia diagnosis very, very common, more and more patients are being diagnosed with atrial fibrillation. So I think the technology has really helped us in getting these patients treated appropriately. But at the same time, there's the other side of the coin where all these devices may falsely diagnose patients with heart rhythm problem. But nevertheless, I think that is a big reason why we are seeing more and more atrial fibrillation.
So, Dr. Tabra, Dr. Mani outlined a whole bunch of risk factors for cardiovascular disease, right? So, which one of these cardiovascular risk factors play a big role in for atrial fibrillation? Are there specific ones that are more for the electrical disorders versus the plumbing issues like the coronary artery disease?
So I think there is a significant overlap between the risk factors for coronary artery disease as well as for atrial fibrillation. For example, aging is a big risk factor, smoking is a risk factor, hypertension, diabetes, heart failure. In addition, sleep apnea is again a big risk factor for atrial fibrillation, as is increased alcohol intake. And family history, especially in younger relatives, is again another risk factor for developing AFib. So while there are a lot of overlapping risk factors, I think sleep apnea, alcohol, they are kind of more pertinent to the causation of atrial fibrillation.
So, what you're basically telling us is this increased consumption of alcohol, along with sedentary lifestyle, increased incidence of obesity, definitely explains some of the increased incidence of this rhythm condition called atrial fibrillation.
Very true.
Excellent. So, then the next question is for Dr. Mani. So, Dr. Mani, everybody talks about heart attack, right? So, what exactly is a heart attack and how is it recognized? And what should people do when you recognize that they are experiencing a heart attack or their loved ones is experiencing a heart attack?
A heart attack is the most common way by which people die from heart disease. And, what basically happens during a heart attack is, if you think about the heart, that this is the most tonically active muscle in your body. It beats once every second from the instant that the heart forms at about 10 or 15 days after conception, all the way out to the last second of your life when you die. And in fact, you could go so far as to say that the beating of the heart is actually the what we call life itself. And I know people will talk about the difference between brain and life and brain death and heart death, but the heart beating is essential for our real perception of life. Now, occasionally what happens is that this muscle has arteries that supply the muscle that give it oxygen and nutrients. And these arteries, due to aging, due to blood clots, or due to injuries, can sometimes get blocked off. And when they get blocked off, what basically happens is that heart muscle that's downstream of the blockage starts to die. This is represented to people by a sense of doom. Your chest can hurt. People can have discomfort in their chest, cold sweats, difficulty breathing. But that's what you commonly see when you watch a movie, that people are clutching their chest and they're having a heart attack. Unfortunately, a significant proportion of people, particularly women or people over the age of 70, tend to have a lot more in terms of atypical symptoms, where they can present as unusual kinds of chest pain, jaw pain, sometimes shortness of breath. And so it can present in many ways, but the most common way would be when they experience pain in the middle of their chest. The correct way to identify what's happening is to get help. And the safest way to get help is to call 911. One of the things that I don't want to go across, and this is something we see all the time, is, well, I'm going to drive to the emergency room. I certainly wouldn't recommend someone driving to the emergency room in the midst of a heart attack. And what's worse, I don't want someone to be driven to the emergency room by somebody else while they're in the midst of the heart attack. And this has happened enough times to my patients where I'm dealing with someone who comes in with a heart attack, but they had to stop halfway because they passed out in the midst of their heart attack and the ambulance had to be called to the expressway. So, getting to help, getting to an emergency room is essential, but calling 911, getting the EMTs out to where you are is key in terms of identifying this early and getting to help in terms of restoring the blood supply. One of the things that's really important to remember is these arteries are sole supply to the heart muscle. If they get blocked, heart muscle cells will die. The unique thing about heart muscle cells is that they are usually hard to kill, but once you get rid of them, they never come back. So it's an irreversible loss. Timely treatment of heart attacks is key to prevent excessive heart muscle damage and to save lives. When you get brought to the emergency room, the first thing they do is do blood tests and EKGs. And those are ways by which they can identify whether you are truly having a heart attack. And if you are having a heart attack, particularly if you are in an ACC or Joint Commission certified, acute MI care center, you'll be taken to the cath lab rapidly or administered medications rapidly to restore blood supply and restore heart function at that point in time.
So there's a lot of conversation about the clot busters they give you through the IV versus putting in a balloon in your coronaries and opening up the blockage and putting a stent in as a scaffold. Uh, when do people get these clot busters versus the angioplasty stenting versus when should somebody get a coronary bypass graft?
That's an excellent question. So, think about the clot busters like the water that's sprayed by the fire services when they come to a house that's burning. It's just generally spraying the water and hoping the house cools down. The difference is when we go in and do a balloon or a stent, it's a much more directed process, which means that we're able to limit the potential bleeding side effects by reducing the amount of blood thinners we need to use and by treating the segment that's diseased and not just treating everything. When I give somebody a blood thinner, especially the clot busting medication, it goes to every organ system, which means that the potential risk for bleeding in all those sites goes up. As a result of that, most contemporary situations are directed by where we're able to direct the treatment specifically to where the problem is by treating the clot and treating the blockage right then and there with a balloon and a stent. It is unusual to use bypass surgery for heart attacks. Usually, patients that go for bypass surgery have chronic stable disease involving multiple arteries rather than a sudden blockage that causes a heart attack.
All right, I think that makes a lot of sense. So, Dr. Singh, the next question is for you. So, building on what Dr. Mani told us, obviously, getting these clogged up vessels is no fun, but it looks like it's inevitable to some degree, one way or the other, depending on your family history or the risk factors that you carry. So, I mean, there is a lot of conversation about this whole calcium test or what they call the calcium CT. Can you tell us more about what exactly this calcium test is and how is it relevant for your coronary artery disease? And should everybody get a calcium CT scan? And depending on what number should one be worried about?
Yeah, that's a great question. So, yes, there is significant value in getting a coronary calcium scan, especially if somebody has a family history of coronary artery disease or other risk factors. It serves as a more accurate predictor of future heart attack and stroke risk than other conventional things such as cholesterol, blood pressure screening alone by providing a very direct look at the plaque burden in one's heart. So, what calcium in your coronaries essentially means that there is already hardening of the arteries by the process called atherosclerosis, which is seen in calcium deposits that, as we were discussing, is a sign of old plaque. While calcified plaque is a more stable than soft plaque, its presence is important to know because it indicates that the disease process has already started in an individual patient. And the more calcium that they have, the higher is their likelihood of significant blockages elsewhere, because it is one vascular tree. And therefore, obtaining this information from a coronary calcium scan is extremely useful for tailoring treatment strategies in the future, such as aspirin, statin, or counseling on future cardiac event risk rate.
So the higher the calcium score, higher is the risk of possible advanced coronary disease. And these are the patients where you need to aggressively look for more definitive tests like coronary angiography and possible interventions and all. So in your opinion, what age patients should consider getting a calcium score if they're worried about coronary artery disease?
Yeah, the typical recommendation for all the risk factor scores is typically above people above the age of 40 years of age. Now, if you have, however, family history of early coronary artery disease, then it will be useful to get it even sooner, depending on how early heart disease or stroke disease history exists in your family. The other thing that is important to understand is we're talking about screening of asymptomatic patients with risk factors with a calcium score. If at any time a patient has symptoms that may be thought to be linked to heart disease, then one should go a full coronary CTA, which is a more specialized test. It requires giving iodinated contrast to look at soft as well as calcified plaque and the amount of narrowing of what we call stenosis that is existing in the heart arteries. So anytime that there is symptoms, we should do a coronary CTA for evaluating plaque and stenosis. But for asymptomatic patients for risk assessment, a coronary artery calcium score is good.
Thank you, Dr. Singh. The next question is for Dr. Soslin. I mean, as many of our prior speakers have alluded to, often women have less dramatic presentation of cardiovascular disease. How is this different, and why is it different for women? And what should they do to be aware of such situations? And how do you preemptively screen women? And what strategies should one employ in this type of situation?
So it's such a great question and something we kind of tackle all the time when we're seeing our patients in and out of the hospital, because women, it's not so much that the blockages in itself is different or the disease process is different, but women's presentation can often be so very different that it gets missed a lot of times. And so like Dr. Manny mentioned earlier about patients having chest pain, and that is the classic symptom, which we all want to remember, but in women patients, it can be so much more vague than that. And so it often gets missed. So rather than a woman having classic chest pain, it might be like shortness of breath with activity, or it can even be like nausea, vomiting, acid reflux type symptoms. People can get pain in their backs or in their necks or in their jaw. They might feel lightheaded or dizzy could be their presentation. Sometimes they just start having trouble sleeping or feeling anxious or a lot of anxiety and they don't know why. Also, it can be like exercise intolerance. Like a lot of patients may look and say, okay, a couple months ago I was walking 2 miles on my treadmill. Now I can only go 1 mile. Or I was carrying a basket of laundry up the steps with no problem. Now I'm getting short of breath with doing that. So a lot of times it's more vague. And women often really struggle with when they should see a provider or talk to their doctor because these symptoms really sound like, oh, they might be nothing. Oh, I can't sleep. That could be many things. I'm going through menopause or other things that could be triggering that. Or I have a lot of stress at home. Or, we blame our symptoms on everything. So it's hard to sometimes differentiate. And I have many patients who are like, oh, I feel so stupid going to the hospital because it's probably not my heart. But we don't know if it's your heart unless you go to the hospital. So if you have any symptoms or any concerns with any of these changes in your body, it's really important to let your doctor know or go ahead and get checked, because nothing is stupid to get checked until we know for sure. And, some people think, oh, my reflux, it's just that, but that can feel just like heart symptoms. So it's always good to get checked if there's any kind of changes in quality of your symptoms or how you're feeling. And I think that's part of it, is that women get to the doctor late because they're not clear on when their symptoms, what they are or when they started, or what it's related to. And so a lot of times we get treated with poor medicines or not as good of healthcare or not as quick of healthcare because of our later presentation to our doctors. So.
Thank you, Rachel. I mean, sticking to the women's and cardiovascular disease topic, again, this is another hot button topic for Dr. Singh. Hormone replacement therapy in postmenopausal women. Yeah or nay from a cardiovascular standpoint?
Yeah, so at this time, major professional societies, including the American Heart Association, recommend against the use of menopausal hormone replacement therapy for the primary purpose of coronary protection. While there is some evidence now that may suggest that menopausal hormone replacement therapy that is initiated within 10 years of menopause or before the age of 60 may reduce coronary heart disease risk, more data is needed in this area because we also know that menopausal hormone replacement therapy, or HRT, consistently increases the risk of stroke and clot formation in the veins regardless of the timing of initiation. So overall, the summary verdict would be yay if you are in early menopause and are using it to treat symptoms such as hot flashes, then you may get a bonus heart protective effect. But the verdict would be nay if you're well past menopause or have known heart disease already, so what we call secondary prevention, then the risks, they typically outweigh the benefits. The method of delivery is important as well. So transdermal, for example, patches and gels, they are often preferred over oral pills because it carries a lower risk of forming blood clots as well as stroke.
So it looks like there is a pendulum swing in the other direction now. So definitely area of good study, at least from an arrhythmia standpoint. We do see that a significant improvement in symptoms of palpitations or dysautonomic symptoms in patients who get on hormone replacement therapy. So looks like this is going to be a subject of greater debate and greater research in the years to come.
Sounds good. Yes.
And this next question is for Dr. Cabra. If a patient has a newly diagnosed atrial fibrillation, what should they do? Should they go for a medication or should they go for this procedure called catheter ablation that has been widely popular in the cardiovascular space nowadays?
Thanks, Dr. Lucky Reddy. So when people are diagnosed with atrial fibrillation, we have to keep a few things in mind. Number one, we need to make sure their heart is not speeding up because atrial fibrillation significantly increases their heart rate, and that can cause a lot of symptoms, and sometimes it can cause weakening of the heart muscles, causing heart failure. So I think the primary goal in these patients is to control their heart rate. And secondly, we want to make sure they don't have a stroke, so they need to be started on blood thinners based on their risk factors for having stroke. So once we do these two things, then we come to the next step, which is should we get this patient back to normal rhythm, and if so, how? So generally, when people have newly diagnosed atrial fibrillation, we always try to get them back to normal rhythm to improve their symptoms and to decrease the complications associated with atrial fibrillation. We can achieve it with the shock treatment, which we call cardioversion, or we can do procedures like catheter ablation, where we insert wires from the veins of the legs into the heart, and we disrupt the abnormal circuit which causes atrial fibrillation. And sometimes we also give them medicines. So which one is better? So being an electrophysiologist, I think with the current technology, with the advent of new technology called pulse field ablation, we are taking more and more patients for catheter ablation as it offers a safe alternative to medicines to control their heart rhythm. But again, the fact of the matter is we have to individualize these treatments. So once we get patients' heart rate under control, once we decrease their stroke risk, that's when we discuss with the patient which arm would be better for them. And many times we start out with, say, medicines and then go on to ablation. The beauty of ablation is patients don't need to take lifelong heart rhythm medicines, which are not necessarily safe alternatives to catheter ablation. And I would like to get your insight as well, Dr. Lucky Reddy. What what are your thoughts? Which one would you recommend for your patients when they first come to see you?
No, I think, I mean, you said it correctly. I mean, there is a lot of individual variation in how we deal with these things based on their comorbidities. And especially if somebody is relatively healthy, no major comorbidities, and they can tolerate a minimally invasive procedure that lasts 60 to 90 minutes, you're looking at not having to deal with the side effects of antiarrhythmic drugs or the side effects of blood thinners. And you almost have a near curative, even though atrial fibrillation is never 100% cured. So I would say it's a near curative procedure where you have a dramatic improvement in your symptoms and quality of life without having to be condemned for lifelong medication. I think the answer is really simple. If you have a fib and it is symptomatic and you really don't want to be on long-term medications, I think catheter ablation is an amazing choice. So as somebody says it, ablation is salvation, right? So thank you for that. The next question is for Dr. Manny. A lot of times people have chronic coronary artery disease for multiple years and occlusions in multiple different places. They had angioplasties, stents, bypasses. And so somebody was talking about this chronic total occlusions and the value of opening up these chronically occluded vessels. There is a significant amount of debate in this particular space, whether somebody should be thinking about opening up these chronically occluded blood vessels or simply treat them with medications. What's your take on it? Uh, how do patients deal with the situations like this when these type of scenarios come across?
So it's an interesting and incredibly widespread disease. So different surveys have looked at this, and some surveys say up to 1 in 3 people who have a diagnostic angiographic procedure will have at least one chronically occluded vessel. So the biggest thing that patients ask me when we talk to them about these vessels is, how can it be 100% blocked? How can there be no blood flow going to the heart muscle? How am I alive? How am I not having a heart attack if it's completely blocked up? And the answer to that is usually what happens is that the body builds internal bypass channels that go around this. Now, just like anything that's a makeshift construction, these are makeshift blood vessels, so they don't necessarily supply normal levels of blood flow, but just enough blood flow to keep the muscle alive, which means when you exert, you're going to get out of breath a lot sooner. When you try to do stuff, you'll start slowing down. A lot of people will accept that and say, doc, I'm getting older and I just want to take things easy, and this is just a sign that my body is telling me to slow down. But a lot of people don't want that, and a lot of people want to continue to remain highly functional. And this significantly limits their ability to do things. So, what we can do is reconstruct the blood vessel and actually rebuild the artery again. And this can be done either surgically with a bypass or by special procedures that we can do to rebuild these arteries. Now, obviously, both bypasses and these special procedures tend to carry a higher risk than a straightforward angioplasty and a stent, but the overall risk is marginally more. People have done large surveys and they've seen that the overall risk of life-threatening complications with a regular angioplasty and a stent is usually to the order of 0.5 to 1%. In the case of these chronically blocked vessels, it varies somewhere between 1 and 2%. So it's a small increase in the percentage risk. It doubles the risk, but the risk is only doubled from about 1% to about 2% to get these blockages fixed. The improvement in symptoms is real. There could be potential benefits with regards to restoring heart function. And there's actually data out there that indicates that if you have a successful procedure where the blood vessels restored blood flow, you actually will live longer and have less heart attacks if the procedure is successful. Now, those studies are very often what we call retrospective studies, and they don't necessarily address this problem like we do with a lot of the other studies that have been done. The problem with doing prospective studies with chronic occlusions is no two patients are similar. That the the variety of disease that we see is so diverse that it's sometimes hard to make this. And similarly, you kind of have to individualize it to a patient. If you're not able to do the things that you want to do because of this disease, then fixing the blockage is something that you need to get done. On the other hand, if you're able to do everything in life that you want to do, and that's the question I often ask my patients, is there anything that you want to do that you're not able to do? And if they say, no, doc, I'm able to do everything I need to, I usually leave them alone and treat them with medications and use risk prevention strategies for the future. But if somebody is limited by what they can or cannot do because of this disease, I think it's a fair shot to offer them the treatment because the incremental risk is there, but it's a small risk. And it's something that I often discuss with people before we go ahead and do this.
That makes a lot of sense. So there are options even for these so-called end-stage coronary disease with multiple blockages, chronic occlusions, where you could restore blood flow to the myocardium or the heart muscle and really change the quality of life. Excellent. So this next question is for Dr. Soslin. Rachel, there's a lot of chatter about this new weight loss medications. There are a ton of advertisements from Novo Nordisk and Eli Lilly and a whole variety of places. So about these GLP-1 drugs. What's your take on what its impact on coronary artery disease? Is this something that patients should be thinking about? Should they take it or not? And tell us more about this.
Yeah, so DJ, like you say, I mean, it comes up in clinic all the time. Everybody wants a quick fix for their weight and a quick, easy way to lose weight, and they think it's going to modify your heart disease. And I guess what we need to understand is how it actually works a little bit on the heart, and are these drugs safe for the heart? And we don't know all the information, but what we do know is there's some protection of heart disease by reducing some vascular inflammation in the vessels. It can also help improve like the cell lining, the blood vessel function to some degree, but really they're designed for diabetic patients initially, so they help decrease your glucose. And sometimes by losing weight, by just the weight loss in general, as losing weight from any type of diet, it will lower your blood pressure, it will lower your cholesterol. So those are all cardiac benefits that we can get our diabetic patients under better control, which then is less dangerous for their blood vessels for heart disease. The problem is we don't really know the long-term side effects of taking these medications. The other thing is a lot of times when patients stop taking the medications, then they gain their weight back. So they often have to stay on them for an indefinite amount of time. And these medications are not completely risk-free. People have a lot of side effects on the medications. Some people get nausea, constipation, a lot of different GI side effects. I've had some patients that feel dizzy on the medication. So it's really a one-on-one type of discussion with your patient as to their degree of obesity, what their goals are in using these medications, you know, what their intent is in terms of long-term use of the medications, is the cost-benefit ratio worth it, and discussion with their heart disease and how the benefits can be manifested for each individual patient.
So there is a lot of hope. There is some mechanistic data that's already generated, but the long-term impact on the progression of coronary artery disease is yet an ongoing study with many more new exciting things to show up in this front. So thank you for that. This next question is for Dr. Kamra. So Rajesh, Dr. Mani nicely talked about myocardial infarctions and the heart attacks and loss of heart muscle. Oftentimes, cardiac arrest, which is an electrical abnormality that results in the stopping of the heart, happens as a result of heart attacks. So it's quite a no-brainer that if somebody had a cardiac arrest, yes, they need a cardiac defibrillator to protect. Are there any other scenarios in the context of coronary artery disease that somebody should be thinking about a cardiac pacemaker defibrillator?
Thanks for asking that question, DJ. It's an important one. So yes, people who have had a cardiac arrest, they need defibrillator for secondary prevention. That means they are the patients who have the highest risk of having another cardiac arrest, and this device will improve their survival. But we also need to consider defibrillator in patients who have not had a cardiac arrest yet, but are at risk of having cardiac arrest in the future. So who are these patients? So based on uh, uh, huge and multiple epidemiological studies, these are the patients whose pumping function of the heart is low. So people who have congestive heart failure, who will benefit from defibrillator to improve their survival. And then there are other categories like patients who have inflammation in the heart muscle, a condition called myocarditis. They are at a very high risk of having arrhythmias. Patients who have some genetic condition like hypertrophic cardiomyopathy, who also demonstrate some high risk factors, some patients with some electrical abnormality like long QT syndrome. So there are a lot of these other conditions where patients would benefit from a defibrillator to improve their survival.
Excellent. So these are definitely life-saving devices, and this is something that and patients should be seriously looking at in order to have further protection from these untoward incidents that can cause cardiac arrest. Thank you for that. So this next question is for Dr. Singh, right? So we talked about heart attacks, we talked about risk factors, medicines, interventions. A lot of times there is a standard question about, do you have his family history of cardiovascular disease, right? Which can be an arrhythmic condition, or it can be a heart failure type of a condition, or coronary artery disease. So when somebody says that they have an inherited cardiac disease, what do they mean by it? And how should they be further risk stratified? Does everybody require a genetic test or not? How do you deal with this type of a situation in your clinic, Dr. Singh?
Yeah, that's a great question. So, when dealing with inherited conditions, for example, hypertrophic cardiomyopathy or HCM, or an arrhythmia problem like long QT syndrome, the approach is more specialized than managing general heart disease risk. So, one should document their family pedigree while paying very close attention to sudden unexplained deaths in the family, especially in people who died unexpectedly before the age of 40, including what we call as accidents like drowning or single car crashes that could have been caused by a sudden cardiac event. To note anyone in the family with a history of heart failure, pacemakers, or other cardiac devices. So, obtaining a detailed family history or the pedigree is extremely important. Now, these patients would benefit from seeing a specialist such as a cardiologist, genetic counseling, and have clinical screenings or tests to detect the presence of disease that may then lead to more specific treatments, lifestyle, and precautionary steps. For example, hypertrophic cardiomyopathy, certain competitive level activity restrictions may be required, especially for younger athletes, or for long QT syndrome specifically, many common over-the-counter and prescription drugs, they can trigger dangerous rhythms. Therefore, seeing a cardiologist is imperative when you have a family history or current symptoms for such specialized conditions.
Excellent. Thank you for that. So the next question is for Dr. Mani. February being the heart month, what are your top lifestyle recommendations for cardiac health for our patients?
I'm glad you brought this up. The best way to avoid both complications of disease as well as expensive procedures is prevention. It's by, leading a healthy lifestyle to start with, which is managing your weight, managing your diet, moderation in your diet, avoiding tobacco, moderation with regards to alcohol, and having a regular exercise program. One of the things I often tell my patients is rolling stones gather no moss, tombstones gather moss. And so it's really important for people to realize the importance of physical activity in doing this. And, I think one of the things that is important with this is it's not only the role of activity and diet, but also collaborating with your primary care and your cardiology physicians to understand what your individual personalized risk is going to be and how you're going to be able to manage that risk moving forward. Dr. Singh spoke about use of risk assessment tools that factor in the family history as well as your individual risk factors to determine an individualized plan rather than just using generic plans that GLP-1s are good or statins are good or aspirin is good. It's figuring out what works specifically for you and what risk factors exist in your individual case. Medicine has advanced to the point where we're able to tailor make medicine to reduce individual risk for patients. And I think that needs to be the focus of precision medicine moving forward.
Excellent. So with that, I want to wrap up this session with a couple of questions, right? I think there is a significant shift towards the type of fast food that we're eating. There is a increased consumption of really bad food that is not homemade or home prepared. I mean, whether it's busy lifestyle or the convenience of really ordering Uber Eats or anything else like this, you see a lot of shift of younger generation really dealing with high blood cholesterol, hypertension, obesity at an unusually young age that we are seeing now than we never saw when we were all in training many years ago. What's your take on this phenomena, and what should parents do, or what should young adults do not to fall into this trap of fast food, uh, quick dinner, quick lunch, quick breakfast? And what are some of your advices? Maybe each one of you can give your take on it. Maybe we'll start on the right side of the screen with Dr. Singh.
Yeah, thank you. These practices are obviously easier said than done, right? So I would say, like, start with small things. So maybe it would be something like meal prep over the weekend, because, many times the households are both mom and dad working in order to support kids, and they may not have time to do detailed dinner prep or morning breakfast every day. But I would say, hey, if you have the weekend to yourself, if you were to do meal prep, so as to you have like your main protein groups or a salad cut up for the rest of the week, then that way it would help you rather than going for quick options, through a gas station, some other things. But if you have something half made at home, then you add the final touches that might be more convenient and feasible. And then again, start low, go slow, but that would allow you to stay steady.
Rachel, what's your piece of advice to our audience here?
I'd say those are really good things. And like you say, I mean, with sports and stuff, families are out late lots of nights during the week, and it's hard to like make a lot of foods. But if you do eat out, I would say make healthy choices from the menu. Like if there are salad choices or things that are more like not avoid fried foods, avoid things that are really high in sugar or high fructose corn syrup. Also, like for your kids, choose snacks that are, I mean, there's a lot of packaged snacks now that also have some health benefits to them. So it's not just all like a lot of carbs and things like that. So when you're like shopping, just try to pick things that have more protein and are healthier foods for your kids. And actually, they'll kind of pick up on it also. And my kids have kind of, they might start picking vegetables and fruits if they're available, easy to them. So if you just leave it, like Dr. Singh said, getting some stuff ready ahead of time, then they'll pick the healthier snack, hopefully.
Thank you for that. One last question before we wrap up for Dr. Cabra. Stress seems to be an important factor in many of these things, right? Overeating or increased cortisol levels and everything else that goes on. Your 30-second solution for stress reduction.
DJ, I'll just quote the study which I think you published a few years ago about yoga and atrial fibrillation. So again, yoga is one way to reduce stress, and not just for atrial fibrillation, but for cardiovascular disease. It has been shown to significantly improve outcomes. So again, there are several techniques to decrease stress, but definitely there is a strong link between stress causing inflammation, causing cardiovascular disease. So anything we can do to do better there would be great. And I would just like to quickly add to your previous question. I think one of the places we can really make difference in terms of better food menu is in the schools. So if you look at the kind of the menus in the school, many of that menu is not what would be recommended by a cardiologist. So I think our organizations, American Heart Association and American College of Cardiology, need to kind of work with the school districts and give healthy options to our kids.
Excellent. I thank you all. I think keeping ourselves away from the phone and away from your social media apps for a considerable period of time on a daily basis, putting in a deliberate attempt to do that, I think is very helpful. I appreciate you all taking your evening off and getting on this webinar to really educate our patients and share your thoughts.